Uh, Peculiar case renal transplant last almost 3 years. Today is the 45th episode of Peculiar case renal transplant. And we have a very important topic today, and the presenters are known for their clinical expertise and the communication skills. And we have a good panelist. And just introduce you, it's my duty to introduce speakers with and the panelists for a few minutes. Then, without wasting time, we'll go into the discussion of our main TMA and cortical today. Today we have two speakers. One is Jittu Kurian, as assistant professor of Pushpagiri Medical College Hospital, Tiruvalla. I just went through his CV. It was very impressive. From schooling from basic IPSC, Kottayam to SPI to Lucknow. He has very impressive schooling. And, somebody's voice is
There's an echo somewhere, no?
sorry. So now he's assistant professor in Tiruvalla. He has carved a niche for himself, and he's a very very handsome person. Is leading the program in Pushpagiri Medical College transplant program. He has done few cadaver transplant, ABO compatible, and he has got a lot of publications. Research one is very impressive, also like rituximab in nephrotic syndrome, and he has got a notable academic role in it's a mentorship in Glomcon International Fellowship Program. He is teaching is his passion, and he's now emerging as emerging a wave of excellence in the entire spectrum of nephrology. I could see the way that he grows. Jittu Kurian will be walking us through a case that not only highlighted the clinical nuance, but also reflects the real world uncertainty what we face in everyday life in transplant. So welcome, Jittu. And Dr. Satish Balan is going to support Jittu Kurian's presentation. So as I know, Dr. Satish Balan, we know everyone from the Peculiar Case group, and everyone who encounters him is a witty, warm, and wisdom-filled contemporary. And I admire not only for his deep clinical thoughts and insights, but for his ability to distill the complex thoughts into razor-sharp one-line rhetoric. Whenever anybody asks questions in the WhatsApp group, his answer will be razor-sharp. So I truly consider him as a true Aquarian mind. I think he's always a few steps ahead of everyone. I welcome you, sir, today. I think it's a TMA is going to be important topic for everyone's interest. Today we are going to have evidence informed and some ground value and bedside management of a TMA from a case presentation. So we have another case by Dr. Varun from Vijayawada, Andhra Pradesh. He has finished his BM nephrology in 2018 at Ramchandra University, and he is now proud possessor of amazing array of certifications he has, and his CV is very impressive. And associate professor of Dr. Pinnamaneni Siddhartha Hospital Medical Science and Gannavaram, Andhra Pradesh. So he has presented at international, national, and the regional level. The one thing which caught my attention was the international level was The Hope is a Walking Dream, a short film in ISN. He's won the best award for short film in ISN Abu Dhabi 2020. And he has 27 publications to his credit, and he has written few book chapters like inborn errors of metabolism and pharmacogenomics in hypertension management and cardiorenal syndrome. I welcome Varun for the cortical necrosis. You are going to talk. It's a very there are myriad causes, and it's a miserable end for the patient as well as for the doctors sometimes. So this is a very critical thing you are going to talk, and we will derive some information from your talk. And the most important thing is today we have a good panelist, two panelists. One is Dr. Arad, Associate Professor of from Nephrology of PGI Chandigarh, and Dr. Arun Kumar, Associate Professor again from IIMS Delhi. So I and Rajarajan are proudly honored to welcome the two distinguished panelists today. They are widely known for their exceptional blend of clinical expertise and academic scholarship and research-driven teaching. That's what we could see from distance. With many years of experience in kidney transplant, with added exposure to TMA in their practice, I think they will add more flavor to our understanding today. Both are passionate educators and clinician scientists. They continue to bridge the gap between a bed and the bedside. So since they are sitting in the teaching institute, individuals such of high standards often ensure that evidence-based medicine drives with policy and practice in renal transplant. We are truly privileged to have them lead today's discussion. I think we will have very impactful, insightful messages today from both of the panelists. So we will allow more time panelists to share their views. First, I welcome Dr. Jitu to start his presentation.
Thank you,
Can
sir.
you sh-
Thank you for this opportunity. And I'll just share my slides. Okay. My slides visible?
Yeah, of course. You
Okay,
can make
fine.
it.
Yeah.
Okay, fine. Fine.
Thank you so much and for this opportunity. And I'll be going through this case with some kind of little bit theory in between. But if that is not required, or if Dr. Satish is covering it, just let me know and I'll skip the slides. So this is a case of a 32-year-old female who is para-1 living one with history of gestational hypertension, and she came to us with proteinuria for 1 year. Her creatinine was 1.5 and she had nephrotic range proteinuria with an active urinary sediments. Her immunological workup was negative. We did a biopsy, which is not really a great biopsy because we got only 3 glomeruli, out of which 2 were sclerosed, and the IFTA was 30% and IF was negative. So we thought probably it's a poorly sampled FSGS in this sample. And we started her on anti-proteinuria therapy and was started also on steroids when she didn't respond to the initial anti-proteinuria therapy. This was in May 2023, and she was with us for about 2 to 3 months. And then she was lost to follow-up. Her creatinine was around 1.8 to 2. And then she presented to us about 6 months later when she came to us with a redness and a greenish discoloration of her toes, which initially was looking like a snake bite. But she didn't have any history of snake bite. Neither did her evaluation had any features of so. She had advanced renal failure this time with an active urinary sediments, and her blood pressure at the time of admission was about 240 by 120, and she had features of papilledema. There was drop in hemoglobin with an elevated LDH. We did look for schistocytes, which was not there. All the immunological evaluation, including ANA, ANCA, anti-GBM was negative, and her APLA workup was also negative. The C3 was initially low, which was subsequently repeated and found to be normal, and the C4 was normal. We did dialyze her and did a biopsy, and this biopsy was interesting to see that there was a lot of thrombi within the major vessels in the afferent arterioles, and there was schistocytes. The afferent arteriole had thrombi within, the wall had necrotic debris, and the glomerular capillaries were fairly spared, but the afferent arterioles and the major vessels were having a lot of thrombi within with schistocytes. There was focal duplication of the GBM, segmental sclerosis, and IFTA was 50%, with IF being negative. So this was a case of a thrombotic microangiopathy, which because of thrombotic occlusion, there was end organ damage, and she had features of microangiopathic hemolytic anemia with thrombocytopenia. But not every time you get a biopsy with like this, or not features of MAHA many times. And it could be just a biopsy proven TMA when you do a biopsy of the kidney, and that could be the only feature of a thrombotic microangiopathy. So when we saw this, these were the things we thought, and we had to keep this patient in one of these boxes. So this is very important because only if we keep the patient in the right box, that's the evaluation and further treatment gets right. So is it primary or secondary? Of primary, we think of a classical sugar associated HUS, which is the typical HUS. Is it ADAMS 13 related, which is a thrombotic thrombocytopenic purpura, where thrombocytopenia is the predominant lesion and renal failure might not be that much. Then comes the complement mediated TMA, which is a diagnosis of exclusion, which means to say that we rule out all the other causes. And if that is all negative, then we think of a complement mediated TMA, which might have a genetic mutation, positive or negative. Then you have the inherited forms, which are non-complement mediated, like the DGKE, the cobalamin deficiency, etc. The secondary ones are pregnancy, postpartum, drug-induced, post-transplantation, autoimmune like SLE, scleroderma, renal crisis, malignancy, and last but not the least, the very important malignant hypertension, which brings in confusion. Because is it the malignant hypertension causing TMA, or is it the TMA with malignant hypertension a part of an atypical HUS? So this was where we placed our patient, and these were the two differential diagnoses we had: hypertension-induced TMA or a genetically mediated TMA which is presenting to us with malignant hypertension. So how do you differentiate these two? Because a complement mediated HUS more than 50% has malignant hypertension. That's like a big number. And all the essential hypertension or secondary hypertension, what we normally see, they may also rarely lead to TMA, about 15%. And if you take all the malignant hypertension, a small component can present with complement mediated HUS. So that means to say that when you have a TMA with hypertension, we really don't know what you're dealing with. And that is the confusion. This is a scoring system, not validated, but gives you an idea whether you're dealing with a complement mediated HUS. So the +1 suggests that you are looking in terms of a complement mediated HUS, and the negative suggests that you're looking away. So if a patient is a female, young female, less than 45 years, family history of HUS, there is no history of hypertension, no LVH, and if the patient requires dialysis, these are all pointers that you're looking at a complement mediated HUS. And if the hematological parameters resolve with treatment of blood pressure, then that is against a complement mediated HUS. If you have a low C3, persistently low C3, factor H and factor I level, that is suggestive of a complement mediated HUS. If you have no thrombi in the glomeruli, that is again suggestive of a patient who has got no HUS. There means no thrombi, there's unlikely to be a complement mediated HUS. So looking at our patients, all the starred ones she was a female, less than 45 years, no LVH, she required dialysis, she didn't improve, her hematological parameters didn't improve with optimal control of blood pressure, and her glomeruli didn't have thrombi. So this was again a confusion because malignant hypertension-induced TMA versus complement-mediated HUS. These are the pointers favoring a malignant hypertension-induced TMA because her first biopsy was FSGS and she presented to us with hypertension. So to us, this is good enough to tell that this is a hypertension-induced TMA because the first biopsy didn't have features of TMA. There was enough baseline IFTA to suggest that probably the second insult of hypertension has what resulted in her advanced renal failure. But the point against malignant hypertension was there was no recovery, the complement levels were low, and that she had this leg lesion, which was not explained just by malignant hypertension alone. So we were still in confusion. We didn't have eculizumab, so there was no thought process block there. We gave few sessions of plasmapheresis, multiple blood transfusions were given, patient was oliguric, AVF was created, and we evaluated her transplant workup. So I'll skip this slide. So when you think of complement-mediated HUS, why do you need to bother so much? Because that is very, very important because it requires further evaluation. If it's a complement-mediated HUS, it has treatment in the form of complement inhibitors. It is a poor course if not treated with complement inhibitors. If you think of a transplant prospect as a related donor, then if it's a genetically mediated complement-mediated HUS, we have implications by selecting a donor. The recurrence of post-transplant also matters when it comes to complement-mediated HUS, and treatment prior to and post-transplant also is important if it's a complement-mediated HUS. So these are the factors. There are multiple factors pro amplification of the complement and inhibitors. If there is a loss of function of these inhibitors, like complement factor H of complement factor I, the complement regulator, the MCP factor I, etc. So there's a loss of function of the inhibitor, then you have unregulated complement activation. You have gain of function of the amplification loop, which produces more C3, which is very crucial. That can be causing unregulated complement activation and atypical HUS. So the starred ones are the ones which are very commonly seen as a recurrence in transplant and also commonly found. So how do you evaluate the complement? Either you can do the complement pathway evaluation, you can evaluate the components, you can evaluate the complement split products and also antibody towards the complement. So the complement pathway can be separately activated on an ELISA plate, which autoterminatory pathway, complement classical pathway, mannose binding lectin pathway. The components are C3, C4, CFH. The CF products are C5 factor B, C5b2, C9, the complement products, and you have anti-CFH. But the most important is the genetic studies. And also we need to look at the trigger because many a times the patient has got an underlying genetic mutation, but the reason for them to present with an atypical HUS is a trigger like pregnancy, like an ischemia reperfusion, an infection, etc., or even a surgery. So when you come to the genetic studies, we can do a genetic panel which is targeted, like the complement factor H, the SCFI, MCP, the regulator genes, ADAMS13, CFB, etc. You need to do the copy number variants at CFH and CFHR, which can be missed in a whole genome sequencing. You need an MLPA for the same, and you have non-complement mutations like TMA and DJK, which need to be looked at. You can do a whole exome sequencing, which is not expensive, and you can do a family and variant testing also. So in our patient, we had a C3 which was initially low, then it became normal, then we CFH and anti-CFH was done. The CFH was normal, anti-CFH was negative. We did a whole exome sequencing with MLPA, which showed no pathogenic variants. We got a call for A5 mutation, and it was a heterozygous mutation with X-linked, and it was reported as likely pathogenic. The MLPA was subsequently negative. But we looked at the family history or the patient evaluation. She didn't have any features of an Alport syndrome or anything to suggest this genetic mutation, which we didn't look at as an important one. So if you look at a genetic study which is negative, it was found that from the global AHUS registry data, about 60% of the patient has no documented complement gene variants. So, and it also depends upon the clinical scenario. So, for example, if the patient is in pediatric onset, if a patient has got a pregnancy associated HUS, the chance of you finding a mutation is high as compared to a patient who's got HELP or a STEC HUS, where the chance of finding a mutation is very, very less. And when you look at it, when do you look for the genetic mutations? If you have a patient who's got ESRD due to TMA, younger patients with malignant hypertension and TMA, pregnancy associated TMA is very, very important because this could be a manifestation of underlying complement mediated TMA. When there's a family history of TMA, obvious. And when you have an unexplained renal failure in a multiple family members of the patient, you need to look for genetic mutations. I'll try to skip this slide and I'll come to this slide. When you look at genetics, it is not that easy. It is an autosomal dominant, but it is not a Mendelian pattern. The incomplete penetrance makes it even complicated because just the penetrance is 50% with epigenetic and environmental factors playing a role. The most common mutation is the CFH mutations. We have a lot of CFHR deletions which are seen in Indian population, and some of them are associated with CFH antibodies, and some patients even can have multiple gene mutations. Our patient underwent a live-related transplant with mother as the donor. With ATG induction, she attained an RD creatinine of 1.1. Her TAC levels are fairly okay, but her hemoglobin failed to improve even at the month of 1 month. She had iron deficiency. When we evaluated, her LDH was 700, but schistocytes are negative. Her creatinine was 1.1. But at the end of 3 months, it was not happy again. She had new onset worsening of hypertension. She had proteinuria. The creatinine was mildly worsening. The albumin was normal. The hemoglobin and platelet counts were normal. We thought it is a recurrent FSGS, or is it an ABMR? We did a biopsy, and this was what we found. She had fibrin thrombi within the glomerular capillaries. There was a lot of mucoid intimal edema. There was segmental sclerosis at areas, and there's a lot of ischemic ringling presenting as efferent arterial thrombus and ischemic ringling. So the graft biopsy didn't have features of in tacrolimus toxicity, nor did it have any features of rejection. It just showed acute thrombotic microangiopathy. To summarize, we have a patient who has hypertension with proteinuria with mild renal dysfunction to present it, and we thought it is FSGS. She presented a few months later with severe renal dysfunction at MAHA, and that was biopsy proven TMA. With genetic workup and complement workup being negative, we found out that post-transplant, she recurred with proteinuria with renal dysfunction, and this time the graft biopsy showed a renal limited TMA. So is it a recurrence or it's a de novo? We evaluated her with ADAMS13. Antibodies were negative, levels were normal, TAC levels were normal. The ABMR donor-specific antibodies were negative. CMV, PKV was negative. Autoimmune workup was negative. So we came to a diagnosis of recurrence of complement-mediated HUS. But at this point of time, we didn't have the wonder drug called eculizumab, but when it was exclusively expensive, we could not afford. And this is a patient who probably requires a lifelong therapy because she has recurred in a renal transplant. So coming to our case, we did a few sessions of plasmapheresis, knowing that the plasmapheresis exchange only will help in an anti-CFH antibody. Her creatinine stabilized to 1.7 initially, but now it's progressively increasing. What next? We're not sure. We're trying to procure a compassionate eculizumab, and in Mumbai, KEM, they are having some opportunity for that. We're trying to explore that. But we are trying to, the take-home message is that we need to attempt to look for the possibility of a complement-mediated HUS in many of our patients who have biopsy-proven HUS. Low threshold for genetic studies, about 40% complement-mediated HUS can have no identifiable genetic variants, and an absence of an identifiable genetic variant is not evidence of absence. And renal limited TMA is a common entity. Worsened proteinuria can be a sign of TMA, and complement inhibitors are the only way out. Till we have access to it, I think this patient doesn't have a fair, good future now. Thank you so much for this opportunity, and I hand over my mic to Dr. Satish for further.
Thank you, Jitu, for that wonderful case presentation. Unfortunately, the case is wonderful for us, but not so good for the patient. It's really a conundrum. So the problems here that she definitely seems to have a genetic. She had a TMA before transplant. She had a TMA after transplant. So we had to assume that the two things are connected. I cannot think of two reasons. One cause for TMA before transplant, one cause for TMA after transplant. Though it's possible. It may be that she had a malignant hypertension or an advanced CKD-related TMA in the first case, and post-transplant it was due to tacrolimus, even though the levels were normal. But it seems a stretch of imagination to put two different causes. So like you said, I think this looks like a complement-mediated TMA. The other point is about the genetic finding. So when you have a genetic finding of likely pathogenic mutation, the X-linked Alport's type of thing, it is always penetrant. It's a penetrant mutation. So probably she had a mild form of XLAS, that is X-linked Alport syndrome. And that will explain the FSGS and the proteinuria and all that in the initial biopsy. But I don't know if the two things are connected. So I'd like to open this up to the audience. I would ask Dr. Raja to comment upon this because it's really a very perplexing case.
Thank you, Jitu, and thank you, Balan sir, for asking me my opinion on this case. So I think I don't have anything more to add, but if I had to interpret this case, so the generally complement-mediated thrombotic microangiopathy, we take it as synonymous with acute kidney injury, like they present with acute kidney injury, like creatinine of 6, 7. Most of the time, it's advanced kidney injury. But if you carefully look into the literature, what they state is you can have all spectrum of manifestations in the sense that you could have simply an hypertension. Hypertension here obviously is poorly controlled or refractory hypertension, or it may be called malignant depending upon the organ system they involve. The second could be, acute kidney injury, or it could be simply a nephrotic syndrome because of the repeated insults. So in that case, you do a biopsy, you will have the MPGN-like pattern with no immunofluorescence staining. So if you want to make it a very simplistic, then it could be like it's actually a complement-mediated thrombotic microangiopathy, not a very malignant one. Why I say not a very malignant one is the initial presentation is not very bad. The post-transplant also is not very bad. So one may say that in between the patient went into ESRD. So that could be, because of hypertension, the patient is having a damage, the kidney is injured because of the complement or the malignant hypertension. And, there might have been spurts of increase in blood pressure, which could have resulted in a rapid downhill course. You will all agree that, malignant hypertension or accelerated hypertension is one of the acute factors resulting in progression of a chronic kidney disease to end-stage kidney disease. If I have to put it like, it's easy that way. And we, as you rightly pointed out, both of you, like, we never know what the genetics is also playing. Like, it could be very much possible that the proteinuria or the FSGS was, could be related to the Alport part. If you come to the oddities of, the complement-mediated malignant hypertension, a general, feeling is like, if it is because of hypertension, it is more of microangiopathy. And if it is because of complement-mediated disease, it is because it is more of thrombosis. Although, they are not always like that. I think the pathologist would be the best person to, dissect the two. But odd points for complement is, one is she was able to successfully undergo pregnancy without actually having any advanced kidney injury. That's an oddity, because among all the triggers, blood loss, surgery, and infection and pregnancy are the strongest triggers. Probably she had wonderful obstetric care. That is what I would assume. Then the C3 level normal. Generally, C3 level low means less than 70. So this patient had 80, but 30 to 40% only have hypocomplementemia. And the first biopsy did not have thrombotic microangiopathy. So I feel that this patient probably has a complement-mediated thrombotic microangiopathy, but not of a very severe mutation. See, generally we say 60% is positive in genetics if you do from the best setup in the world. And if you see the Indian patients, I think if you ask me how many of you have seen a true CFH reported from India, I would say that I only seen Dr. Balan's report in Kidney International report where they worked up a case very well. And somewhere here, the serological tests will help you. If you do a MAC, that is C5b9, the C5b9 is elevated, or if the AH50 is elevated, there you can strongly say that, this is related to a complement-mediated disease. So I think with this, I will stop, and I'd also like to hear others' opinion.
Yeah, thank you, Raja, for those very enlightening things. I think we got a little bit more clarity, but still we are in trouble because we don't have a proper diagnosis. I think Valentin is also here. Valentin, are you
Yes.
online? Can you comment on this?
I think between you and Dr. Raja, you've covered almost everything. I was just curious about one thing. It was mentioned there was no ADAMTS13 antibody. Now, why was the antibody done? Was the activity low? Because you wouldn't do an antibody unless the activity itself was low.
So we done the ADAMTS13 level, and ADAMTS13 antibody is what it is sent. We had sent it to Manipal. That was it is reported, like the ADAMTS13 levels were adequate.
It is. They generally test for activity. I think antibody is done after the activity level.
Exactly.
So it's the
That is correct. But the activity was normal, no? Anyway.
Yeah, the levels were normal.
Okay. So if the
activity is
enzyme
normal.
levels were normal, then if the activity was normal, then that almost rules out the presence of an antibody anyhow. Yeah, I mean, between the two of you, not much really more to add. But yeah, the other thing is whether there, what Dr. Raja said about C5b to C9, also an AH50 might help you, because that again is evidence of alternative pathway overactivity. Very shortly, we'll start doing the GPI anchor deficient test at KEM by flow cytometry, which will again tell you about factor H in vivo activity. In vitro activity of factor H, protective activity. I think within another couple of months, we'll be able to offer that. Otherwise, nothing more to add from my side.
Thank you, Valentin. I think that's very good. Vail.
Arun should have his say. Arun Kumar?
Hi everyone. I think almost all the points have been completely covered. Only one thing is what we have noticed is that if the TMA is because of accelerated hypertension, usually there is a predominant arteriolar involvement. There is no glomerular involvement. Whereas with a complement-mediated one, we expect both to be predominant. I think that is something which we'll have to remember. And complement deposition in IF need not be there, because most of us or most of our students, when we discuss, they are like, if complement deposition is not there, it is not complement-mediated TMA. It is not like that. And with regard to anti-CFH, what we have noticed is that sometimes in ABMR, during ABMR, we have had 2 patients in which anti-CFH levels were slightly elevated. It was in the levels of 200, whereas in normal atypical HUS, the classical ones, we have it in the levels of thousands usually. So these patients, we had given some plex during as a part of ABMR treatment. And after that, they didn't require any further therapies. So I'm not sure how did this happen. We don't have an explanation for it, but I think probably doing an anti-CFH for this patient would be important. And one other thing is probably there is this COMPASS trial which is going on. Crovalimab is being given, and it is also available for post-transplant recurrence if the native disease has been proven to be AHUS. I think they're recruiting till April. Sorry, sir. Crovalimab, which is an anti-C5b1.
There are at least 4 centers in the country which are doing, which are recruiting for crovalimab. I think Dr. Siddharth Sethi at Medanta, AIMS Delhi, AIMS Jaipur, and IKDRC Ahmedabad. I know these 4 centers are definitely recruiting.
Yes, and I think the recruitment is there till April end. So if at all there is a chance, because this is one of the first trials in which the kidney transplant recipient has been accepted into the trial. Otherwise, it is usually for native disease. So that is probably an option, because this looks like a classical TMA otherwise.
Preliminary data which some of them have shared suggests that crovalimab is really good, working well for them.
That's good, actually.
I think especially in the pediatric population, I think they have got good results. They have extended the trial into adolescents and adults, and I think probably that is something which we can think of this patient.
Only problem would be is if this patient doesn't have microangiopathy, I'm not very sure whether this patient will get enrolled because these trials have got
Yeah.
very stringent criteria.
Yes,
Like that's the
I had
problem.
spoken to Dr.
And-
I had spoken to Dr. Sethi, and they have strict criteria, and they need to have
Yeah.
microangiopathic microangiopathic hemolytic
Yeah, that
features,
is the
not be a
problem.
renal empty.
Yeah, I had problem with my previous patient with TMA on dialysis because she also didn't have thrombocytopenia. We could not get her into an iptacopan trial at that time.
Yeah.
Ongoing. One important thing that eculizumab may soon be available. Astra is bringing it out
June.
hopefully by June.
By June,
So
they have told.
it might cost might be affordable. I don't know. They have still not decided on the price.
Someone had told me it
They
is
are
around 1
lobbying
lakh.
with the government for to include their brand under the rare diseases scheme.
Sir,
It
probably
will
I think
continue
they are
to be
not including in
expensive.
the rare diseases scheme now, sir, because they have already got an approval for bringing it to the market. So it may not go into the rare diseases scheme where they have quoted a higher price, it seems. So this is probable. I'm not sure whether it'll go on that way, but
So it would not be reasonable to include that in the rare disease because you also have a competitor which would be much less expensive because most of these trial sites are government sites and there you take the lowest one. So I don't think it can compete.
The other drug is iptacopan. We did do the trial, the Appelhurst trial. We were one of the centers. We managed to recruit 3 patients. 2 of them who had failed plasma exchange responded to iptacopan. But now Novartis has stopped recruitment in India.
Yeah,
So
they've stopped. Even we
that's the
also did
problem.
the same. Yeah.
Satish sir, there is a question from Rajalochana. In young female with unknown low C3 whole exome sequence is negative, what other test would you like to do to rule out AHS?
Yeah, of course. Whole exome may not be enough. You will have to do a DNV test, MLPA, of complement factors, and that will give you whether there are any deletion duplications. So that has to be done along with it. In all cases of complement disorders, when you are doing a genetic test, you should be doing both tests for SNVs and for CNVs. So this whole exome plus CNV test like MLPA.
Is it like C3 glomerulopathy like presentation or acute kidney injury? Because I'm not very clear. Only C3 being low means like is it TMA part or is it C3 glomerulopathy like presentation? That I'm not very
Yeah, that's also there. One of the other things is that just because there is a low C3 doesn't mean that it is a HUS. Many of the end-stage renal disease, they may have a low C3, which is not very low. 60 seems to be compatible with C3 alone. So I don't know how far we should go with this evaluation.
Yes.
I think this is a nice point because what I've noticed right now is many of us tend to, if we see a C3 around 50, 60, we don't know the cause. There is a microhematuria, we send a genetic mutation, and like what this case I had, we had a couple of cases with Alports. Probably we're picking other diseases, but none of the classical complement mutations.
Yeah, I agree.
I think I actually searched for any cases of Alport syndrome with HUS, and I couldn't find any literature on that.
Incidentally, we are having one patient right now, sir, but we have diagnosed it as CNA-induced TMA because in the previous one he had with mTOR also, and we are trying for belatacept for that patient, but that patient in the genetic evaluation, he got Alports again, post-transplant. Yes, it's a second renal transplant at our institute. First was outside. We did the genetic because he was having a recurrent TMA, and it turned out to be Alport. So I'm not sure. Probably
interesting. It's also the same, no? Whether there is some connection, we have to find out.
And I think it will be worthwhile to actually repeat the genetic testing if you are finding too many Alports in a patient with TMA. Like are we on the right track? So that is also another thing that's important.
Satish, it might be worthwhile here to send it to one of the reference labs like Paris or Newcastle, because how reliable is our genetic testing is something that we're not very sure.
There was a study some time back in which it showed that many of the tests done here, I think Raja only talked about it, if I remember right.
That was sad. That was sad. Like duplications, especially, none of them actually turned out. And what they said was probably the control only had one, so everything is duplication. Every normal would be duplication. So.
I think should be. Anything to add to that? Anybody else?
It's a very nice discussion. Somebody's asking low C3 patient, should we look for AHUS C3 glomerulopathy?
That's,
I think Dr. Lobo can comment about this. See, one way is if we have a good complement laboratory, C5b9, AH50, and C3 nephritic factor. If C3 nephritic factor is positive, I don't, but you can never be 100% sure, but you can be reasonably sure that it's probably along the lines of a glomerular disease. And if C3 is negative, then there is a reasonable possibility, I will tell again, because C3NF is going to be positive only in 40%. It'll have only a positive predictive value and not a negative predictive value. But that is one way, but I'm not very sure like whether Dr. Lobo's lab is doing C3NF.
Yeah, we are doing C3 nephritic factor. The yield is not very great. When I last looked at it, out of something like 150 samples processed, about 12 we had with high values. So it's like percentage, about 8 to 10%.
Exactly. We also did, when we did it in 115 patients, and what we got positive was only 30 patients. Like, you know, we might have tested 150 because also added 30 patients post-transplant. So I agree, like even our yield has been...
Did you use an ELISA or SHIP RBC lysis?
No, we used an ELISA technique only.
And that is the problem, because we also use an ELISA. And when we wrote to the Newcastle lab saying, can we quality control our method against yours? They said, we are using SHIP RBC lysis.
They will not, they didn't agree to us as well. Like, you know, they said, like, you know, we cannot validate your findings, but yes, we can give you positive or negative. That's all. Like,
I think C3 nephritic factor, does it change in CKD? ESKD? No, it doesn't.
Should
not.
So it will all have positive predictive value. Don't think about negative. If it is negative, like if it is positive, then at least you can be sure that, okay, even if C3 glomerulopathy comes back, you will manage it plasma exchange, or it's going to happen after some time. So it's not a absolute contraindication like TMA, like, you know, that would be an absolute contraindication if you know beforehand that it's a bad disease.
Okay.
I think the question is whether would you advise transplant for this patient again, considering that she's still young? If at all she comes in one of the programs, at least probably.
At least
1.7 is a creatinine.
Yeah,
1.7 is a creatinine.
Right.
It's
now,
worsening, sir. It's worsening now.
This worsening is what he had completed and was not sure.
Yeah, it's worsening now. So I think
because in the rare disease program, you don't have these kind of stringent inclusion-exclusion criteria, where I think the nephrologist has the rights to, you know, or I wouldn't call it right, but nephrologist has the, you know, preview to, you know, put a final note that this is complement-mediated thrombotic microangiopathy. It needs to be only validated by the internal scrutiny committee, whichever does it, like, you know, and they are generally favorable. They don't overrule the nephrologist diagnosis at PG, I can tell you. So there, I think one of these programs, if she's able to go, it is good. But only thing is, you know, it's difficult to get. It's easy said than done. Believe me.
Okay.
It looks good and you discuss in a talk and other things, but they're not as just like maneuvering through a government hospital. Just think about that.
Okay.
So somebody asked, see, could it be malignant?
Yeah, malignant deficit. I think we already discussed that point.
The slides were very informative, but I think it's joined later.
Could be, but it seems stretch of imagination to say that there are two causes for TMA, one before transplant, one after transplant. So,
Jitu, I've got a few messages from my personal number. Your presentation is very impressive. They want it in a PDF. Actually, you are you just connected with your presentation, all the theory very well. So I think a few people have asked for conversion into PDF. Send it immediately and in a group sharing, right? Would you agree to the remind of people?
I'll send it, sir.
Yeah, okay. It's very nice actually, right? Please send it, made it as well as a few messages I got from the our group people. So Raj, are you there? Rajarajan?
Yes, sir.
Yeah, please, I think you also a few things and please share your views, Rajarajan.
Yeah, it's a wonderful, I'm dumbstruck with the presentation and discussions actually. And thing is, we do see a lot of TMAs. No, we are stuck with what to do and next and all. And is it possible to send it to Pune, Lobo sir lab? How can we send the sample? Is it possible for the logistics forward? If we want to work up the patient for a TMA, or
You,
Raj,
yes,
they've shared
we
many times
can
the
do
number.
most of the tests for you. We are using, if you want ADAMTS 13, it has to be citrated plasma. All the other tests can be done on serum. So separated serum, preferably on dry ice, especially the activity assays like AH50, CH50. If that serum is frozen, thawed, the activity goes down. So you send it to us on dry ice and we aliquot it as soon as it arrives. So we also don't end up by freeze thawing the sample. So I can put up on the group the instructions on how the samples are to be sent and how we process, if you like, on the follicular transplant group. I will put up those instructions.
thank you very much, sir. Thank you very much. Thank you.
Okay, so can
We
we
can-
have a list of tests with cost? Yes, we will, somebody asked for the list of tests with the cost, we will share in the group, so that's, I think, a very relevant question they're asking. So we'll move to the next presentation by Varun. Varun, are you there? Just, you can
Yes,
take,
sir.
yeah, please, you can share your slides, you just go ahead. Yeah, please go ahead, Varun.
Yes, sir. Is it visible, sir?
Yeah, yes, of course.
Okay.
Good. Your voice is
So,
clear, please.
thank you for the opportunity. And sorry, my presentation is not as excellent as D2 has done. It has done a very good job. It's a very simple case. I just go through what we faced in doing the transplant. So he's a 29-year-old gentleman who had presented with cortical sinus venous thrombosis in 2019 when he was diagnosed to have membranous nephropathy. After that, he was asked to follow up. He took native medications for about 3 years, then again turned up in 2021 with ESRD. So he had membranous with CIN. He was initiated on maintenance dialysis. Then he was worked up for renal transplant. Father-in-law as a donor, CMV D plus R plus, CDC cross match was negative. And because of logistic issues, we did not have a HLA typing, DSA, TAC polymorphism. We just in the initial days, we only had CDC cross match available with us. So after this, in October 2022, he underwent a ABO compatible transplant. Induction agent was thymoglobin. In our center, we use only 2 mg per kg single dose with steroid pulse. Warm ischemia was 1 minute, cold ischemia was 32 minutes. Rewarm ischemia, the anastomosis time was a bit longer. And in fact, this was the first transplant in our center. So even the surgeon had bit time, so delayed anastomosis. We started him on tacrolimus 4 mg per day, that's also low dose, mycophenolate 2 grams per day, and oral steroid 60 mg per day. So if we see the TAC, it is less than 0.1 mg per kg. Initial output was good. There were no interop complications. Post-operative maintained output of 1 liter. Creatinine decreased to 1 by POD2. BP was stable. Previously, he was hypertensive on 3 drugs, and now BP was stable without any drugs. And he also developed post-transplant diabetes. Sugars went up to 180 to 200. So he was fine up to POD5, but on POD6, the creatinine started going up. Output started coming down. BP went up. Needed antihypertensives. So since it was POD6, first team empirically we started on steroids and we planned for biopsy. So if you can see, these were the reports. Immediate post-op day 1, there was a pancytopenia. This could most probably be because of ATG, which gradually improved. To day 5, HB was on an increasing 10. Then from day 6, it started dropping. And that is when the creatinine started going up. So there was initially pancytopenia, but there was no thrombocytopenia at this episode. So this is the trend. Creatinine improved, and this is the platelet count. Initial thrombocytopenia improved, and hemoglobin also improved initially. Then from day 6 onwards, started dropping down. And this correlated with the rise in creatinine. There was a drop in HB with increasing creatinine and worsening WBC count. So the rejection was suspected and was planned for biopsy. First year was done and biopsy. Unfortunately, I do not have the biopsy images available right now. Here on biopsy had 11 grams, out of which 2 was cirrhotic, and fibrin thrombi were found in 6 out of 7 grams. There was no other much signs of any rejection, only except from I2, interstitial inflammation. And there was the diffuse tubular epithelial injury, diffuse ATN. So biopsy report was a TMA with ATN. C4D was negative. There is no PTC involvement or vasculitis. His complements were normal. Previous was did not show any schistocytes. So at this stage, we were worried whether it is rejection or not, and especially we started him on first year already. So one possibility was AMR, but his there were no involvement of PTCs, and C40 was negative. So we thought there's a possibility, and then we thought maybe possibly it could be either infection related or TAC induced. So we started him on plasmapheresis on POD8 and POD10, and tacrolimus was switched to cyclosporin 400 mg per day. Mycophenolate and steroids continued. After the second session of POD10 was the second session of plasmapheresis, and POD11 he started developing fever with leukocytosis. There were no localizing symptoms for the fever apart from generalized fatigue and reduced appetite. Forex catheter was removed on day 11. Cultures were sent. This urine culture was sent after the forex catheter was removed, and he was started on meropenem. So day 13, then we got the culture report. As you can see, it is a pan-resistant organism. It was a Pseudomonas aeruginosa, which is MDRO in the urine. Only intermediate response to colistin polymyxin B, and rest everything was resistance. So now we had a dilemma: what to do with the antibiotics and what to do with the creatinine. So colistin polymyxin intermediate, that could have been a choice, but we could not get him to get the drugs from outside. In our institute, only meropenem was available at that time, and it was other drugs they have to be bought from outside, and which was costly for the patient to buy. And so now we had MDO, what to do. So two things which we considered as whether to give to start him on antibiotic potentiators, and as it is a case of pan resistance, to overcome drug resistance, we can use a supraphysiological dose to reach the MIC levels in the blood. So again, when you look at the MIC, the best was fluoroquinolones. Next best was carbapenem, meropenem. So what we did, we started him on high dose meropenem. Initially, for his creatinine GFR, the requirement was about 1.5 grams per day. We gave double the dose, and we also added EDTA with that. So after 2 days, there were no further episodes of fever. Appetite improved in 3 days. Creatinine stabilized at 2. So for 2 more days, it was continued, and for POD15, a repeat biopsy was done to find out the cause. The repeat biopsy showed 10% of the cortex was necrotic. Out of others, it's 16 grams. They were plated famine thrombi, but it's coming down. Initially, it was 6 out of 7, now it was 3 out of 16. And there was endotheliosis. No signs of ejection now. So he was continued on antibiotics for 7 days. Creatinine stabilized at 2 milligrams, did not worsen. Diabetes mellitus reverted after stopping tacrolimus, and he was discharged on day 21 with cyclosporin, mycophenolate, and steroids. So this was the time. This was the time when first session of plasma was done. This was when second session of plasma was done. Afterwards, the count started going up. So this you can see. So this is the platelet counts. This is fine, and you can see hemoglobin initially improved. Then once the fever started developing, this was the first episode. When the creatinine started jumping up, there was drop in hemoglobin. Then after plasma, it improved. These two are 2 sections of plasma phase. 2 sections of plasma phase, again hemoglobin improved. Again with fever, it wasn't. Then after, this was when we changed over to meropenem high dose with EDTA, then afterwards there was improvement. Similarly with creatinine. From day 5 onwards, there was slow rise. This was when biopsy was done. Then it slowly started going, stabilized at 1.5, then plasmapheresis was done, stabilized at 1.5, 1.6. Then I think this is the time when UTI picked up, and then he manifested fever. So this was a fever spike that worsened the graft function from 1.6 to 2.2 to 2.2. Then after changing the antibiotics, it stabilized. Now it's maintaining at 1.9. So for creatinine was stable at 2 milligrams. Then after 3 months, he developed candidiasis. Creatinine again went up to 2.6. Again, the same problem with the cost. So we could not, we had to go with others. We added fluconazole and reduced cyclosporin by 1/3 by monitoring the CSA levels. So he recovered from that. At 2 years follow-up now, he is stable with a creatinine of 2.1, no further episodes. So diagnosis was high-validated donor with ATG induction and triple immunosuppression. Secondary gastrointestinal, first was thrombotic microangiopathy, probably because of TAC, and second was UTI. That UTI was a sepsis because of Pseudomonas aeruginosa resistance. The issues which we had was, first was pancytopenia, most probably it was ATG induced because spontaneously improved. Second was whether this TAC adverse effects, thrombotic microangiopathy, whether it was TAC related, because we had done only 2 sessions of plasmapheresis. And even when we see that before the fever episode, the creatinine jump was not too much. It was 1.4, 1.5, 1.6. It was not jumping too fast to something like sepsis mediated or rejection mediated, and there was no evidence of any ABM on the biopsies. And also, this first biopsy was done almost 5 days before the onset of fever. So it was prior to sepsis, so most probably it was a TAC-related TMA. And he also had a post-transplant diabetes mellitus, which also recovered after stopping tacrolimus. Then other thing was UTI, MDR sepsis pseudomonas. So one contention here which we had was, since patient was on Foley's catheter for a long time, could it have been a colonization? But the 2 points against that was he had a fever episodes at that time when the culture was positive, and that was associated with worsening creatinine leukocytosis. So most likely it was a pathogenic UTI which responded to high-dose meropenem. And candidiasis we had to treat with azoles because of logistic reasons. So again, points to point, it was TAC TMA. Whether he had lingering colonization before which precipitated TMA, I'm not sure. And if it's a TAC TMA, need for plasmapheresis, was it actually worthwhile doing it? And was pancytopenia also because of thymoglobin and or was it because of tacrolimus? Because he has so many side effects of TAC. Could TAC be contributed to pancytopenia? And last one, the high dose meropenem for MD organism. Actually this was the first time I used such a high dose of meropenem and EDTA. Both of them afterwards I have not used before that and not used after that. And third was the last is transplant evaluation. We need to have a DSS and TAC GMAFM, but we could not do because of cost issues. Thank you. So any comments, anything, I'm open to discussion.
Yeah, okay. Thanks, Varun. So did you do second biopsy?
Yes, after 50, at POD 15, the biopsy was done, sir.
Did you repeat again?
No, sir, not after that, sir. From that time, you stable with creatinine of 2.
The story is, the end is good. So acute cortical necrosis recovered now. We thought it's a cortical
Yes, sir.
necrosis. Anyway,
Yes,
but
sir.
a quick discussion to the panelists. Sir, please go ahead.
Yeah, I think, it's very interesting case. So it must have been a patchy cortical necrosis, must have improved.
Yes,
Or maybe one point at which there may be it may have also been probably maybe one single artery which is gone or something like that, one branch or something like that. Maybe you would biopsy in that area. That is also possible. But we really don't know, because I don't think that's tacrolimus-induced TMA producing cortical necrosis will have a good outcome if that's primarily due to the thing. So maybe it's a patchy somewhere, maybe some small area of ischemia that is likely. But of course,
just to add on to
before regarding that.
If I can just add on to that, this was the first transplant which we did, first live transplant. The second one was a cadaver. Even he had a TMA and he had a 15% cortical necrosis.
Oh.
Both of them improved after stopping TAC. So I'm not sure what happened. First 2 cases I did, both of them had a cortical necrosis.
Yeah, so that sounds more like an IRI, ischemia reperfusion injury. So maybe part of the that growth curve in the transplant, learning curve.
Possible.
Yeah.
Somebody asked, why did you add EDTA to meropenem? That's what the question.
EDTA potentiates the meropenem action. It further helps in the destruction of the cell wall. So increases the entry of the meropenem and also helps in destruction of the EDTA itself is an antibiotic, meropenem itself is an antibiotic, but we combine both of them, it potentiates each other's action.
Rajesh, please.
One more thing I just wanted to mention is substituting TAC for CSA. No,
yes,
both
sir.
are CNIs, both can cause. So it is a very interesting choice which you made. Probably
that again we had this thing that usually when in your PG days we had this thing, if TAC is causing, CSA will not cause. If CSA is causing, TAC will not cause. Both of them causing together is very rare.
Yeah, it's a good point.
Yeah.
Rajan, please.
Yeah, thank you. So one thing is whatever we are speaking is like an armchair rationalist. We are speaking in retrospect. So, don't take any comments very personally. So, it's like that. So one is we are reasonably sure that it's not the basic disease which has come back, unlike Jitu's case where there is a debate. And what are the number of arteries? Is it multiple arteries or some sacrifice of the terminal arteries done? Because sometimes you can have cortical necrosis because of that. But fibrin thrombi essentially will not be because of. Fibrin thrombi will not be there in that kind of cases is what I presume. And regarding change from, tacrolimus to cyclosporine, it's not based on some RCTs, but, this is an article in American Journal of Transplant or AJKD, I'm not very sure, by Remuzzi, where they say this kind of a switch you can easily do, conveniently do, and they found that the results are very good. Most of the times the TMA resolves with switch. With respect to use of plasma exchange in TAC-induced thrombotic microangiopathy, I recollect some reports in liver transplant where people have done, and they've also stopped TAC. So remember that, and they said that it's useful. But to be honest, if you look at the mechanism of action, it's unlikely to benefit,
Benefits.
the benefit, yeah, like, But yes, again, when you're managing a patient acutely, you don't know what to do. You are likely to do a plasma exchange. But if you're reasonably sure that it's attack induced, you can switch to cyclosporine and just hold your horses. Like, that's what I would say. So with this, and he also had another level. I'm not very sure what the level was, and one is he also had another surrogate of TAC toxicity that could be PTDM, because you said that reversed after stopping TAC. So maybe the TAC was doing more than what it was intended to do in at least two systems in the body. That's the kidney and the pancreas. So that's how I would see in retrospect, obviously. Yeah. And the question is, like, the next question that comes to my mind, I would also request the opinion of those. You had a TAC-induced TMA, you converted this patient to cyclosporine. So probably lower down, you probably have the patient going into allograft loss for some other reason, maybe BKV or something else, and going. So next transplant you do, it's going to be a second transplant. And what would be your choice of the CNIs? Like, will it be tacrolimus or will it be cyclosporine? I know there's no one direct answer, but I think many of us would be in this situation. Like, this could happen. I would ask the opinion.
Frankly speaking, I have no experience in that, but I to be on safer side, I would start cyclosporine. Maybe the other experts can comment on that.
I think Varun has done an excellent management of this case, no? Whatever it is,
Yeah.
look at it from a linear time progression, it has been managed very well. A lot of unexplained complications occurred, but you took it off and did a good job.
Thanks.
Any other comments on this?
I think we have had a couple of cases like this where again the switch from tacrolimus to cyclosporine has been useful. And where the biopsy was showing some TMA. One was a cadaver patient who had received just cadaveric transplant, who had received just one dose of tacrolimus. But then the biopsy had shown there was renal dysfunction. DGF was there, so we did a biopsy, and one arteriole had shown a TMA. So the TAC levels were not very high, but we shifted to cyclosporine, and the patient miraculously got better. So I'm not sure if a single dose can still cause, but after that we have been quite wary of tacrolimus. So we also do the same. We usually shift to tacrolimus to cyclosporine. It is usually not the other way around. I think Raja sir had asked, probably to confirm it, we'll have to re-challenge with tacrolimus, which I don't think anyone of us will have the guts for it.
That's what.
Now, one of the other points here is probably this could have been IRI also. We are not really sure.
IRI.
Yeah. Maybe, yes.
It is
because
IRI.
the patient also had ATN. He had nice ATN.
Yeah.
That's what he wrote also. Like, he had good ATN
ATN
also.
also.
You shouldn't use the word good, but he did have ATN.
Because all the three drugs, tacrolimus, cyclosporine, mTOR inhibitors, all have been associated with TMA. So I think we may not be left with a choice. Belatacept is probably something which, if available, could be good. We are trying to procure it for a patient. I'm not sure whether it will work out though. So that is one. And usually cyclosporine-induced TMA does not depend upon the levels. Whereas tacrolimus, at least with high levels, the TMA is more thing. But we have had patients with normal tacrolimus levels also. But usually higher levels are associated with more risk of TMA and tacrolimus.
So somebody has asked what is an IRI and you are denying the patient of TAC. So nice question. The only thing is that, see, I think we should not be so antipathic to cyclosporine. Cyclosporine is a very good drug. We have used it for a long time and a very effective drug in the transplant. So probably tacrolimus is much more easier to use and much more that user-friendly compared to cyclo. That's why we are using it. But cyclosporine is not a second line. It's a good drug.
It's just that all of us in our training, all of us, the young people in training, we have never seen cyclosporine. So I think that was one hindrance. Even when we started transplant program, I was wondering whether to keep cyclosporine or not, because I never used cyclosporine ever.
The other problem is probably the cost of cyclosporine. It is compared to the tacrolimus cost, what we are having, it is very high. And in-house, we have a tacrolimus levels, but we don't have cyclosporine levels. So that is another problem which we usually have.
That's a big problem because you don't do CS. Levels are only available outside and it takes time.
And if you go at the evidence on tacrolimus versus cyclosporine, the Elite Symphony had some innate issues with the trial also. Like the therapy was not given to the standard cyclosporine group. and the level that they targeted in the low cyclosporine group was really low. It was 50 to 100 was what they targeted. We all know that 50 to 100 is really low. They don't work in nephrotic syndrome. So, so that's how I would see. And when they looked at the long-term results, even the short-term, it was only biopsy proven. Steroid sensitive rejection was the only difference. In the long term, actually, they didn't have any, glaring result to suggest that one was superior to the other in the elites. So that's how. But anyway, it's all the marketing. What is played low, and because they also had a tacrolimus, so probably that's the reason.
Not
And
sure
you
if
got
that,
They would have.
I'm not sure if that extends to MMF and azathioprine also at times.
There was
Whenever we see these 40-year-old transplants on only azathioprine and steroids, we always think the same key. How did this happen? 20-25 years which are going.
But unfortunately, nobody, even the funding agencies, also are apathy to these kind of trials. They don't clear. That's the sad part. There was one study where although it's tangential, but you mentioned that AZA versus MMF. I think if you look at the
Tricontinental study.
article, yes, one is tricontinental and one is the study from the Italian, from the Bergamo group, from Professor Enzzi's group only, where they reported the 4-year outcomes. It was also presented at the ASN as an oral presentation. They did show that there was no much difference between the two. So yes, you have a point actually. But unfortunately, nobody is having the courage, because you are likely to be ridiculed by, if there is a second opinion, for one or the other reason, you are likely to be ridiculed. That's the problem.
Okay, a few comments in the message box. Somebody said he said attack is a myth. Somebody asked a very relevant question. Would you do a C0 or C2 level? Because when I graduated from ICADRC, we were using only C0, but still I'm adopting that. And the recent generation, since you said you were never exposed to somebody using cyclosporine. So I think you go by the book, but we just generally go by the C0 level. Somebody was asking that question actually.
We use C2. We use
We
C2 level in the first
C0.
year after transplant, and then C0 after the first year.
Same thing. We use C2 initially.
That's interesting. Okay, but we are used to
C0.
Yeah,
we
we are
do C0 in all our
C0 for a long time.
irrespective of the medicine.
Yeah. Actually, I think the C2 was introduced by Novartis as saying that C2 levels is not because we are monitoring C0 levels. That was not good. That's why you had this problem with cyclosporine. If you want a C2 levels and keep it at this range, you will find it's equal to TAC. But to get our heads wrapped around the C2 was very difficult because we are so long used to C0 levels and all that. So I get a level of 100 to 150, I'm happy. It's fine. And lower down there around 100 we maintain, and that will be a good long-term outcome. That's how to look at it. You look at the interesting thing was an Ankevel study published in 2003 in New England Journal of Medicine, in which they looked at the long-term outcome of transplants in Australia and New Zealand. And at the end of 10 years, 100% of patients had CNI toxicity as per biopsy report, 100%. But the cyclosporine levels for that all were around 200 range in those patients at 10 years. So there is probably, if you're going to keep such high levels, definitely you're going to keep toxicity.
So one is regarding the debate of whether C2 or C0. See, if the C2 was so good, I think the Allied Symphony trial would have chosen to do C2 instead of C0. So that goes on to say that probably it's all okay. It's more of window dressing, like you want to show something. So that's one. And the second point is. It went out of my mind. Sorry. you just said some point.
Study.
Yeah, Ankevel study. It was even 400. The first year itself, they showed 75% had CNI toxicity. 350 to 450 was the level. I'm sure that even if you give it to one of the herbivores also, you are likely to have this kind of CNI toxicity, like 350 to 450. So I think. And there is also criticism now that many of the FSGS that we say is related to CNI would not actually be related to CNI. It may be one is donor related changes or probably chronic rejection in one or the other form. But yes, 300 would be too much. Like the recommended now is about 80 to 120. The C0 is recommended.
That is after 3 months, right, sir?
Yeah. No, my own thing is immediately after transplant, keep between 100 to 150. After that, keep it around 100. That will be a thing.
Induction or no induction. Yeah, induction or no induction. So if you're giving an induction, you
Yeah.
can be reasonably, it's okay, like, to
Yeah.
keep that low. Like,
Dr. Satish,
Yes.
it's very Vilas here.
Yes, yeah.
I just want to ask you, Vilas, please go ahead.
It's very easy to do cyclosporin levels in your the same machine.
Yeah, you're doing
And the
Clay.
cost is also same.
Yeah, you're doing
You
with
need to
Clay.
have sufficient samples, no? That's the
No,
problem.
we don't have
Mhm.
sufficient samples. That
Yeah,
is
that's
most
the
of the
problem.
issues.
But the half-life, the shelf life of the kit is more than a year. You
Okay.
need to do 50 or 60 samples in a year. I started doing it in my the same machine where we are doing TAC.
I don't think I'll get 50 to 60.
Uh,
Don't have
Even
that patience.
those nephrotic syndrome people which you are mentoring on
I'm
cyclosporin.
using cyclosporin on nephrotic syndrome. It's all rituximab.
So that's a different story.
Even though the pediatric nephrologists are not yet up to the thing.
Okay.
Lobos is telling,
No,
okay.
he's doing SPLC. But Lobos a different level.
Okay. Okay.
Not our level.
It's a great technique.
in ours, they do the LCMS is the technique that they
Okay.
do.
LCMS.
Yes, they have a lot of, it's an institute, so probably the funding is not an issue. So that's even there, many a times, there are issues with the availability of kit.
Anyway, I'll see that. I'll ask my lab also whether Vilas said, whether we can do it in our lab itself.
Vilas is doing by Clay.
Yeah,
I think. Are you
Clear, no?
Clay?
Yes. Picha, what are you doing?
Clay. It's like it's having meglumimation.
Yeah, I'm doing it by CLIA.
See, I said I've seen with Clay and other LCMS what Raj is telling, but we don't find any difference, sir. If you standardize your lab and your volume is good, and the technician is standard, one person is doing lifelong is staying with you. He knows the real technique of the thing. I think Clay has good things. That's what we have been, and very cheap also, right? Tacrolimus 400 rupees, 500 rupees, and cycle, right? Vilas, how much is costing?
Around 600 rupees, tacrolimus.
We can do as many level as possible, and you can tune your lab according to your thing, and we can easily correlate. And he suggested TAC genotype is a must before any patients on treatment, because it gives a lot of idea about your dosing.
Absolutely.
And the part you manage is more of a infection management. Actually, if you have a multi-drug resistant organism, like I think it looks like a carbapenem resistant enterobacterium, like or multi-drug resistant Pseudomonas, right? Yeah, Pseudomonas. The effective management of infection gives a lot of relief to the graft rather than you are managing with other tacrolimus and that's a big problem in many situations.
Yeah.
So managing a multi-drug resistant organism is it's a double-edged sword. Where to look at either infection or the rejection? That's the problem, right? And you manage well, you give a lot of insights and understanding. And I thank Jitu. All the panelists are a very lively discussion. We silently enjoying all your each and every sentence you made a sense in our practice. Arun, for you and as well as Raja, you made a beautiful contribution. Satish sir, as usual, you backed up by Jitu well. And Jitu presentation was excellent. I got 7 messages from the group. Ask him, would he accede to the demands made by us to make it a PDF and send it across? His presentation was very nice and all differential diagnosis. And Varun, you made a point that I thought you would end up in a negative story. I think it was a positive one, and you gave some kind of algorithm to follow such kind of patients, and you managed well. Every case is different in our practice, so I think we look at your case in a different angle. And we thank all the people who assembled here. It's the highest number we've seen, 120 people. I think this indicates that TME is a big problem in our life. They want to learn something from you, right? I think they want to know something from you. Everyone has got that different parts. Like Vilas said, this attack is misconception of causing this TME. So everyone we have got a different view, but when you're sitting in a particular patient, we know the pain, how to manage, how to get out of it. And your views are really good because you're all sitting in an institution, you see a pool of patients, we see random patients, and the contribution made by you today was immense. And we go with a lot of messages. And thank once again for every one of you, because we stick to time and we end in time. So thank Varun and Jitu and Satyan sir and Raja sir and Varun. all of you. You made a great day today for us. Thank you.
Thank you, sir.
Thank you.
Thank you, sir.
Thank you. Thank you.
Yes, sir.
Thank you.
Yes, sir.